Meeting will please come to order. Councilor Vasquez, would you mind doing the invocation?
Dear Heavenly Father, we thank you for this beautiful day. Thank you for safe travel for all of those that are here and that are attending meetings today. I ask you for divine guidance to have an open mind and open hearts. In Jesus' name, amen.
On to roll call. Yes, ma'am. Mary Baker Shaw.
Present.
Mike Dobbins.
Here.
Bill England.
Honey.
Keith Austin.
Here.
Harley Bezer.
Here.
Joe Bird.
Honey.
Sean Crittenden.
Honey.
Frankie Hargis. Wanda Hatfield.
Honey.
Rex Jordan.
Here.
Dick Lay.
Honey.
Mike Shambaugh.
Honey.
E.O. Smith.
Here.
Denise Taylor. Here. Victoria Vasquez.
Honey.
David Walkenstick. Brian Warner.
Honey.
We do have a quorum.
Thank you. Thank you. Has everybody had the opportunity to review their minutes?
Yes.
Move for their approval.
We have a motion to move for their approval. Do I hear a second? I got a second. All those in favor say aye.
Aye.
Any opposed? Same sign. Okay, is the Claremore Service Unit. George, thank you.
Good afternoon.
Hello, George.
George, how are things going in Claremore?
Good, good, thank you. I'm gonna put a little extra on your, on my report that I send in. Harley's been asking about the number of Cherokee Nation folks on our numbers on our workload down there, so I added those out there to the side.
Thank you.
To go along with that workload, I was going to add that for October, we filled 27,143 prescriptions. We had 7,794 that were mailed out, both locally and from our VA system through the CMOP program. One of our pharmacists, Captain Liesenbecker, was recognized by the Pharmacy Chief Professional Officer, Rear Admiral Pamela Schweitzer, for her leadership as lead for the Tobacco Cessation Services Access. Real proud of her. We are replacing the nurse call system back in inpatient. That's almost complete. The women's clinic remodel is almost complete. You guys are working through the punch list of items there at the end on that. We hired General Surgeon Dr. Doug Wyatt. He started last week. General Surgeon. We also hired Dr. Pablo, Dr. Dan Pablo. He came over and he's actually transferred over. He transferred over Sunday, and will actually start working in January for us. We just purchased a new CareStream portable X-ray unit to upgrade the portable X-ray unit we had. And we had a prescription medication disposal event on the 30th and collected over 22 pounds of medication from patients and staff alike coming in and disposing of those. And lastly, last week we had every year in December we have a Christmas cookie festival. All the supervisors get together and bake cookies, and as kind of an appreciation to all the staff. We open it up to staff and have coffee and punch and cookies. We fill the boardroom up with cookies actually, and they come through and get a couple, get a handful, get a couple of handfuls, and it's a pretty good afternoon. But in appreciation for all that they do, you know, they do a great job there.
Wonderful.
Any questions?
Anybody have any questions? Yes,
Uh,
go ahead, Counselor.
On your workload, the actual numbers versus the CN, I noticed on the new charts, it's 441. There's none under CNN, the reactivated chart. I have to assume that's just, the stats aren't there. When you look at everything else, 18,500 out of 26,000 patient visits were Cherokee. So you get 444 new charts and none of them were Cherokee?
No, I asked about those, and I was told that there was, in order to get the numbers on the new charts and reactivates, they would have to go back and hand count them individually, and I told them, don't go back and count 700 charts.
I assume there was a statistical reason
That's
why
it.
it says that.
There's not a nice little report I can run, like I do on the others.
So it needs to be NA.
Yeah.
NA. All right, that's all I needed. Thank you, George. Make sure I understood that report.
Now, if they come up with one, it'll be on here.
Okay.
Yes, Counselor Buzzard.
George, I just want to say thank you for getting those numbers in. That was kind of important to me to kind of see how many Cherokees were going through the system up there.
Absolutely.
Also, and I forgot, how many beds do we have there?
46.
How many?
46?
Okay, then you had 21% occupancy.
Yes.
Just, and I probably know the answer on revenues, you're like 38.2% down for the same period last year. Why is that now? Is that?
This is for October, for the first month of the fiscal year.
Okay, revenues for
And I think,
2018 decreased.
and if I
Okay.
remember right, we
Okay.
carried over more last year
Okay.
than we did this year, which gets counted
Okay.
in this year.
Okay, thank you, Madam Chair.
George, I have a couple of questions.
Okay,
Could you tell me about contract health? I'd like to talk to you about that.
okay.
Recently, I was invited to be a guest up at Hastings to see the new expansion and all. And while I was waiting, I was right in front of the contract health office. And so I was asking questions about why does it sometimes take so long for someone to be referred? And something that struck me strange was that Claremore, you're all a week late, usually, sometimes, that you all don't send them in every day. You send in the request once a week, and then you deny the first request always. Can you explain this to me, please?
Somebody's giving you some bad information. We don't always deny the first request.
Well, I'm glad to hear that.
The,
Okay. Can you tell
we-
me how it works?
We have a group of physicians that sit down and look at those, and they prioritize the ones, we average probably 300 to 400 a week, and they prioritize those from the most severe to the least, and then we start paying at the most severe, the most critical referral, and pay till we run out of money. And sometimes that's 25 referrals, sometimes that's 150 referrals, just depending on what it is that comes through. But before they go through, before the money's even allocated to those, they pull transfers right off the top, chemotherapy, and dialysis right off the top
Good.
before anything ever even goes to committee. Then whatever money is left over, and appeals, I forgot, appeals that are overturned, whatever's left over goes to that 200 to 300, 300 to 400 that are in for that week and reviewed, and we just pay till we run out of money.
Is that, when you run out of money, is that annually or is it quarterly?
Weekly.
Weekly?
We divide it up. We have a weekly spending allowance. That way, we've got money we have money for each of the 52 weeks in the year. And to me, it makes more sense to allocate it like that than to spend your entire budget in the first 2 or 3, paying everything in the first 2 or 3 months and then have nothing for the last half of the year. So we ration it out every week.
Just out of curiosity, is there any leeway in that based upon the urgency of a situation?
Yes, there's actually within our system, one of the regulations is that if something comes through, say, I'll use Keith here. Say he's got a referral in that's pretty serious, but just missed the cutoff. We have a provision that I can bring his referral back for 4 weeks. 3 more, it can go through for a total of 4 times to try to get his paid for.
Okay. I'm just thinking, if you ran out of money and you've got somebody whose pacemaker stopped and they're totally dependent upon it, do they go to the top of the stack next week? How does this work?
Well, usually it depends on. It's kind of hard to talk in generalities.
Sure, I understand
You've got
that.
somebody that has a pacemaker stopped. We have a cardiologist that comes in once a week. We can get that addressed in-house. They wouldn't be sent out anyway.
Okay,
So if you want to, I mean, if you've got some specific questions, it's a lot easier to address those than speaking in generalities.
okay, I understand it too. How much money, may I ask, are we talking about weekly?
Right now on the CR, we're just over 100,000 a week.
100,000 a week. Okay. Well, I appreciate you sharing that information with me. I was curious as to how that works. But somehow I had heard that you all denied the first appeal automatically, and no, that's not true. Okay, and that you only submit them once a week. So you might check on that,
Now, our committee meets every Tuesday.
okay? So you do submit that information weekly, once a week?
So everything, yeah, all the referrals that come in that are written and come back to us are all put together in committee, and the docs sit down on Tuesday and meet as a group and go through those referrals on Tuesday.
Is that ironclad?
Pretty much, I think so.
I mean, what if you have a situation that really can't wait to be referred?
Oh, Dr. Lang, our medical director, he can approve something if it comes up, absolutely. That's,
Okay.
that option is always there.
Well, that makes me feel better. I may have more questions next
Sure.
month, but I appreciate you sharing this information.
Absolutely.
Are there any other questions from anyone? Yes.
I had talked to Dr. Stallcup on a deal a couple of weeks ago or last week. It seems like we are seeing so many more people that, and the referrals are getting denied unless it's something very major, like, of course, what you said, or a broken bone. I mean, it's come down to that, I guess, and that's what, our constituents are upset because a lot of them are getting denied, but if they don't have a broken bone or something worse, then they're not being accepted
That's
at
correct.
all. Yeah, and that's that's a difficulty on us. I know that's neither here nor there, but when people have worked all their lives and they've got an injury and they can no longer perform a lift or put their arm over their head and they get denied, they can't go back to work. That's a difficult thing for people to accept.
Yes, it is.
And do we have a shortfall? I guess our money, we just don't have enough money to do that.
That's exactly right. I can't spend what I don't have. They won't let me do that.
What kind of shortfall are we talking about? Would you say?
Oh,
What would it take to fix that?
a lot. And I'm not going to give you a number here. You want to get with me at some time? I can, nationally, we send all that unmet need up to headquarters, and those are actually published in reports, the unmet need for contract health.
I would like to.
Is it possible you could share that contract, that article with us? Or with, at least email it to me? I'd love to read that.
Let me see if I can find it.
Sure. I know there's not a person sitting on this table here that doesn't want to help our Cherokee citizens with their health. And if we could be more informed, I think we would be more effective in
Okay.
talking with our citizens. If we could pass on, the more knowledge we'd have, the better off I think everybody would be. Yes, Counselor Taylor.
I want you to tell this group again, something you said impressed me a long time ago, that we see more patients than any other IHS facility, but we do not get more money
That's correct.
than the other facilities.
I have more registered patients than any other facility. I have more registered patients than some areas do. I have, if you look at the OIG report, I have around 110,000 registered patients. If you look at the 2016 report that IHS put out, I have 187 or 189,000. And if you look at the funding that we get, that comes to, at the 110,000 level, that comes to $300 per patient for the year. That's what we have. And I use that, I think on our board meeting, I was showing the disparity in funding per capita between us and national IHS averages, Bureau of Prisons, and VA Health, where it was VA, I think it's 5,600 per capita, something like that. And even the IHS national average was 2,600 or 3,600. It was way above, but we have at Claremore, based on our annual funding from Congress, it's right around $350 a patient.
Oh, my goodness, I had no idea. I thank you for sharing
And
that.
that includes contract health.
My takeaway from that was we're not getting our fair share for the patient load that we have compared to other IHS facilities. We're doing a great job with the money we're getting, but if you look at it patient per patient, we're not getting what we ought to for the volume we're doing. So,
Yes, Madam Chair. When's the last time when we make a request, Dr. Grimm, very seldom do we get an increase from IHS, do we?
I mean, they usually give a lot of their monies out on preset formulas, or just a percent of an increase to your base, things like that. There is one fund, there are a couple of formulas in some funds that have a what's called level of need funded, but it might only be 25% of the formula. There is a whole line item that the Indian Health Service sometimes requests from Congress called the Indian Health Care Improvement Fund. Anytime that one gets asked for, Oklahoma does very, very well because it is consistently one of the one or two most underfunded regions in the country when you look at per capita funding. A letter just came out the other day. They're going to be looking from the director of IHS at potentially updating that formula. So they're putting a group together to look at that. It's been a long time since that formula was looked at, but yeah, that line item is one that is really good for Oklahoma.
From last year's IHS budget, national budget, compared to this year, did we fare okay?
I mean, us in particular?
Oklahoma, we do okay, but nationally, because we're always fighting over this piece of pie here.
Yeah, there's not enough pie for everybody, like George said.
Yeah, there wasn't at lunchtime either with one.
When you do look at all these other systems that he mentioned, IHS used to have something they'd update pretty regularly. I don't remember the last time it's been updated, but would compare us to the VA, to Medicare, to Medicaid, and to the Federal Bureau of Prisons. So that you would see the per capita spending, and we were lower than all those systems at one point in time. I don't know if the Federal Bureau of Prisons is still on that chart anymore.
It was. I think that was the OIG report I saw.
Thank you so much.
Madam Chair.
George, any other question? Yes, Councilor Buster, did you have a
no.
question? Okay, anyone else? Okay, thank you so much.
Okay.
Wishing you a
You're
Merry
welcome.
Christmas.
Merry
Yes.
Christmas to you.
Okay, let's hear now from Dr. Graham.
I have Dr. Stallcup join me up here to talk about some things right off the bat. I got some additional handouts I'm going to pass around to you all. This is just one. And this is our latest recruitment report as of December the 11th. The one that's in your report is always a little old, so we try to bring you this.
All right, I have a few, Madam Chairman, I have a few points to get us started with. I'm sorry I missed last month, but it's good to be back. Thanks for having us. First off, I want to talk about recruiting. Excuse me. And we found something out from talking to these recruits as we go out and visit with them. This meeting is actually, I don't know if you knew this meeting is the #1 search result when you type in Cherokee Health. So our recruits are very much watching this meeting. And so I'd like to say to the recruits out there, if y'all are doctors or nurse practitioners or PAs, we got a great team and great growth, and we'd love to have you aboard. But this is actually a big recruiting function. We didn't know. We don't have that much of an online presence, so that's kind of an interesting fact. We have, in the 8 years I've been here, this is probably the most impressive recruiting report that I have seen. I'd like to give a little public recognition to Stephanie Wycliffe and her department for doing an excellent job. Right now, of new starting professionals, we have 2 docs and 4 advanced practice providers. Of pending candidates, now this is candidates that we're processing right now and they have a letter of commitment. We have 6 docs, 3 advanced practice providers, and 2 dentists. We have more recruits for the health center vacancies than I have seen in quite some time. We had 2 docs sign letter of commitments for Jay on the same day, which is, this is a position that we've been out recruiting for a long time. We have several Cherokee candidates that have reached out to us, and we're kind of finding places for them. So once again, I'd like to recognize Stephanie for doing a great job. This is a wonderful report. This is really going to help us grow our system, I think. Second point, I'll be real quick, and then we'll do questions. There's a little handout here that you may see. They call this an infographic. It's kind of a little detail. So what we did was we wanted to see how we did this October compared to last October. So what we did was we threw out all the doctors that didn't work both months. I mean, obviously, we've onboarded more doctors, so the numbers are going to be better. So we threw them out and controlled it only for doctors that worked October last year and October this year. And what we found was our primary care is up 10.8% in the amount of services delivered to patient. Urgent care is up 51%, and I think that this is reflected in that left without being seen rate dropping because they're processing people a little bit more quickly. And the ED is up 75%. Now, the urgent care and ED have had numerous quality improvement projects going on. Obviously, this isn't just the new contracts that have been issued, but thankfully, in this first month, we have 20 of 58 primary care providers in the bonus range, on track to receive a bonus, and this isn't reflected in this graphic, but we have 10 more that are within 10% of achieving that bonus. So we're very thankful for that. We have some very, very devoted staff that are really working hard to make this happen and serve a lot of folks, and they're going to be rewarded for it, and we're happy about that. Now, the sort of negative that is not on the infographic is that our contract health referrals increased 23% this October compared to last October. And when you serve more patients, there will be more contract health referrals placed, and then you have to make some tough decisions. So I'm going to give you a brief synopsis about contract health. One of the things that has come up, and I believe Councilor Shambaugh was mentioned earlier, is a patient who needs a surgery to work. Right now we are pursuing only categorical denials, which means that we have categories in which we are not funding that category. It's not necessarily on a case-by-case basis, meaning that if someone has an acute orthopedic injury, a fracture, or something like that, that's getting covered. If there is non-emergent or elective orthopedics, that is a category that we are not covering. One of the issues that comes up is, what if a patient needs surgery to get back to work? We actually used to have a program called Back to Work. Some of y'all remember it. It was not funded in fiscal year 15, 16, or 17, but that was $1.9 million to use specifically for patients who needed elective orthopedic procedures to return to work. Well, what happened was, those were the days when we were approving most everything that came through. We probably would lean more heavily on that program now than we would in fiscal year 14. I was still practicing. I've been here 8 years, so I was actually practicing in clinic under that Back to Work program, and it was good for a lot of patients. And I think that the contract health budget is something that we're going to have to look at. We've had the same bucket of money. As you provide more service, as you see more patients, you're going to generate more referrals, and you've still got the same bucket of money you're trying to divide up. And so our budget for contract health for this year is $35.6 million. That's what we're looking for. right now our projected spending is 53.5 million. And that means that we're about $17.9 million overspent, and that's right now with our current restrictions that are in place. And so what happens is, even if we're denying elective orthopedics, that is not enough to impact the budget to the point where we could stay within that $35.6 million. I don't believe that elective orthopedics is enough to stay within that number. To get to that number, we would have to look at, $20 million or so of further reductions. And that would be very, very difficult to do, because you would start getting into some things that we absolutely do not want to. Well, we don't want to cut any, we never want to deny any referral, but, sometimes we have to stay within the budget. And so I think that this is something to consider. I expect that as our services grow and grow, and as we're starting to serve more people, especially if we can start capturing people who have not had adequate access to care for us to recruit them. We talked a few months ago when I was up here about, if you want to capture patients, you have to make it easy for them to be seen. You have to have tons of same-day appointments. You have to be prepared to see them whenever they're sick or whenever they have a sick child. Once we're able to do that and we can start recruiting patients to the system, then we recruit them not only as a patient, but we also recruit them for us to become a payer for their referrals. And so as we see access to care improve, we're going to see people coming into the system that need 6, 7, 8 referrals right off the bat. And there are two schools of thought. One is that $17.9 million of shortfall is overstated. But I think that mathematically that $17.9 million might be a little bit understated, even if we hold to our restrictions on elective orthopedics. So obviously this is a big challenge, and we don't take it lightly. We want to be able to cover everything that everyone needs. We don't like being put in a position of having to deny anything. I ended kind of on a sour note there. I'm sorry. I should have had something good.
Let me add a few things that'll spice it up.
Dr. Grimm's going to say.
I'll bring him back up a little, I hope. So, George mentioned that they have about 300, and I didn't remember, 350 some referrals a week. We have about 372 per day on average over FY17. And we get from the IHS, Dr. Stallcup mentioned our total budget of that, about 28 million comes from IHS. The tribe puts in $6.5 million, the 5% dividend money that you all have helped us get and provide. We put some in from our diabetes grant to help, and then you see the ultimate total there. We've had growth in our CHS over the years, and we knew that we would if we really pushed hard with these new contracts to increase access to care. We knew that CHS referrals would go up too. That's just a natural part of it. But I think we've done a really, really incredible job over the years. Back in 2004, we had 22,000 referrals for that year. And we had 5,400 denials that we just flat out didn't do. In 2017, we had 104,000 referrals and only 2,600 that we denied. So huge, huge increase in our referrals over those years. 472% increase over those number of years. And we actually decreased the number of denials over that time frame. Part of that is sometimes you don't see all the money we spend on this chart. If we do overspend, we have to cover it with something. So, in the years that we have good third-party revenue, then sometimes the system puts in additional funding so we don't have to deny as many things. But Dr. Stallcup is right. As we continue to grow, we're going to need to look more closely at that and, have discussions with the chief's office and with you all about, you may hear more as our access goes up and our money doesn't. But all in all, I think we do an outstanding job with our CHS program. We do referrals every day. I think most of you know that. We at one point did them weekly too. And you all and the chief's office pushed us to increase that. Now we do those every day. So once the patient is seen, either that day or the next, their referral comes in and is starting to get processed, so there's not a delay like that you see. I mean, it's just standard in most IHS places to have a weekly CHS review meeting like that, just because they're busy doing stuff every other day. But we've made a commitment to do that, and we've been doing that for a number of years now. So that's a little bit about our CHS. Couple more quick statistics, and if you have questions, we'll get started. Cardiology is about 28% of our referrals. Oncology, about 22%. Orthopedics, about 16%. And those are the non-elective sorts of orthopedic procedures. Pain management, 7. Ophthalmology, 6. Neurology, 5. Gastroenterology, 4. And then it goes down into the 3s, 2s, and 1s for some of the other things, so I won't go over all those. But cardiology, oncology, and orthopedics, some of our biggest ones. And I know you all are starting to get some complaints about elective orthopedics. We're getting them to, that we're not able to approve all those. And that also is an issue across all of Indian Health Service. There are some IHS sites across the nation that never get to any orthopedics in the way that we're able to here at Cherokee Nation. We're lucky that we have we have our own orthopedic surgeon and a part-time orthopedic surgeon and PA. We're able to do some joints along with some other things in-house locally here too. A lot of sites are not able to do that. Our new site is scheduled to have 5 orthopedists. That's still a couple of years off, but we'll be able to see more orthopedics at that time. We're going to have more ORs capable of taking care of orthopedic surgery at that time too. So we have a vision, for what we're going to do. We got a couple of years till we get there, though. And so, call us when you have issues with patients, and we'll try to look them up and take care of what we can. But the way Dr. Stallcup explained is how we're trying to deal with them right now, sort of a categorical denial. That way we aren't, having to say, well, that patient, is worse than this one on a scale in that same category. If we get to the point where we have the money to do that, then we'll go back into that kind of mode, but right now we're not there. So that's just a little bit about our CHS. Our tribe has done a lot to help us over the years, and the health program has done a lot to help itself over the years, sometimes so that we can overspend what we have been given. And we know that's a high priority for patients and for you all, and it is for us as well. So we'll take any questions that you all have.
Counselor Lake.
Thank you, Madam Chairman. Doc, one of my visions is another doctor each for Oshaleta and Nowata. And I see a couple of yellow marks here on those areas. Can you tell me what's going on?
We have some potential recruits for you.
Do they need to ride to work? I'm willing to.
So, Councilor Lay, there is interest. I know there's been a lot of interest up north. I'll have to follow up with Stephanie on the specifics on those specific candidates, but I know that she's had very favorable interactions with some folks that are interested in the area. She has actually a NOWATA interview, and I can't remember the candidate's name, but I know that she does have one that there's a pending interview for NOWATA at this point.
And I want to say the Oshaleta one, we have a tentative commitment, but the person hasn't notified their current work site.
So we actually have a letter of commitment and we're processing. Now this isn't carved in stone when you have a letter of commitment. We have a letter of commitment and we're currently processing applications on a doctor for Oshaleta.
Good. On this handout, second page, I see a 2-dot thing there above medical director's name, and it said supervising medical director funded by contract health. What does that mean? Are we taking contract health dollars to fund a physician?
I'm still not sure I'm
Right.
seeing where you're seeing.
Right down here.
Oh, down there.
Counselor Lay, I'll have to follow up on that. I don't know about the contract health funding medical director positions. I will say that we have heard the request to go back to a model in which we have a medical director on site at each facility. I'm happy to report that the amount of access and the amount of service delivered to our patients has increased to the point that I think that we are going to be able to do that. That's something that we're looking into. We're sort of identifying candidates now and getting them on a little bit of a sort of a short-term leadership track to do a little bit of training with them so we can kind of reinstitute that. I think it's too much on these docs to have them traveling around that much. They're great leaders. They're experienced leaders. You talk to them. You talk to them at Stillwell, and they love Dr. Baker, but the problem is they love him at, Three Rivers as well. And, you get these guys that are great leaders, and you'd like to just, clone them and send them around to every clinic you got, but I don't think it's really practical. So we are moving more towards having, on-site leadership that's available for the day-to-day.
I think that's a good idea, but I'd really like to know if we're spending contract health funds,
We'll look into
funding a
that.
position, that's not what that money was set aside for. And the other thing, have we lost some doctors at Telequal recently?
Yes, we have. We had a husband and wife team who recently left, and also a surgeon. George mentioned the surgeon that that left Hastings and went to Claremore. And George didn't steal him. He made sure we knew that.
Are you sure about that?
That doctor sought them out. So, yes, we recently have. But, we're in the process of recruiting for those positions as well.
Could you be on that contract funding
Oh,
position
we
as
definitely
quickly as
will
possible?
get back to you
Yes, sir.
on that.
That's,
Yes, sir.
that's totally, as far as I recall, would be outside what that funding is for.
I'm not going to speculate what's there. I hope I know what it means, and that what we should have done. But if I'm not sure, so I'm not going to say anything
Thank you.
until we figure it out. We'll get back to you.
I have a question. How many other physicians have we lost?
Well, don't know that I can answer that. Like from what time to what time? You mean
Just since the last meeting.
recently?
Yeah.
I want to say, is that the only three? Do you know?
Now, I had heard that there was another. I don't want to really speculate and misspeak because there were some people that had some family issues coming up that didn't know if they were going to be able to continue employment. I know we reached out to them to see if there was anything we could do to try to retain them. But I don't want to misspeak on how many the actual number is. But I can certainly follow up and get that for you.
Those three were the primary ones, that you may have heard about. An anesthesiologist, an OB-GYN, that was the husband-wife team, and then one of our surgeons.
By any chance, can you all shed light on how it is going with our raises, our provider raises? Are we nearing the end of getting it all settled and what?
I gave people an additional month, basically, to take a look at their contracts and not stop it at the end of November. And so they have until December the 29th to take a look at those. Right now, depending on how you look at it, we have 11 folks that haven't signed. That's about 9%, so 91% of the people have signed. And we've spoken with one of those groups and think that they're going to sign after we had a meeting with them. And if you do that, 95% of our providers have signed now, so or will have signed after that group does. So we're very, very close, to getting everyone signed in the system. And they do have that option if they want to continue under their old contract as well. It doesn't mean if they don't sign that we'll lose them or anything necessarily.
I want to really thank y'all for passing the budget too, so that we could get those contracts in and get the raises in. That has really dramatically shifted the landscape of recruiting for some of these difficult positions, and that's really, it's done wonders for our patients to be able to go out there into these training programs and these physicians in the community and say, here's a good contract.
Counselor Crittenden.
Yes. The joint venture, now that's going to help the contract health, right? That's one avenue that it's gonna help.
Yes, sir.
If we choose to, to take some of that money, that is, I think, one of the deficits in the joint venture program. They give us 85% of the staffing and operations for that facility, but they don't give you any new CHS dollars with a contract, with a joint venture. So what their assumption is, which I think is a flawed assumption, is that because you have a bigger clinic now and more staffing, you won't need to send as many people out. The good news for us is we have a lot of specialists that most places don't get when they open up a place like this. I want to say there's like 10 or 12, you all have heard us mention them before, different kind of specialists that we'll be getting. And a lot of places, when they open up a clinic like that, don't get that sort of thing. Some of those people will be just running clinics, specialty clinics. Others that are surgical type specialists will be able to do surgery for us too. So hopefully we won't need to send out as many referrals. And we have been talking about, should we, when we get that new funding, should we isolate a part of it to add to our CHS budget, even though they don't give you any additional CHS funding. So it's a little bit of a double-edged sword. We're going to have a lot more specialists, but with no more contract health service dollars. So that'll be something that we have to look at. And I'm hoping with third-party revenue, that will go up too significantly when we open that new location. We'll probably use some of that. We'll identify what we think we need and utilize that.
And Mr. Crittenden, the thing that kind of excites me about it is right now we have some service lines that we have the specialty, but the specialty can't handle all the volume that our patients need, right? And so we are a healthcare provider and also we're a payer. And when we have that, it's kind of inefficient because we can't provide for all the needs. So on the payer side, we still have money going out through contract health. And so one thing that I'm excited about is being able to scale up some of these service lines so that we can truly meet the needs that our patients have.
Counselor Taylor.
Are we looking at an additional audiologist?
Yes, ma'am. So this is something that we're very interested in. There's space concerns and there's some sort of resource concerns with that. This is a big discussion we've been having. This may be a little bit of an offline. I can follow up and get you some sort of data analysis that we've done on this. But we are. Our audiologist is absolutely wonderful. I'm bragging on Dr. Burkhart. He does about 135% of the work of the average audiologist in America. So he's doing like the work of 1 1/3 audiologist, and we are looking forward to getting him some help. Yes, ma'am. So let me get you some data on that.
That'd be great. Thank you, Dr. Stalker.
And we'll have a much larger audiology department too in that new facility. I want to say there's 3 audiologists in
That'd be
there.
awesome. That'd be great.
Counselor Buzzard, did you have a question?
And that was my question about audiology, because I brought that up before, because I know the doctor was answering telephone calls, making appointments, and went up to see him one time, and he was doing it all. I thought, I don't know how you do this stuff. But I just want to say, I want to give a shout out to the ortho people up there. I just had a knee replaced 3 weeks ago, and it's done wonderful. So
Oh, great.
I'd like to brag on our people. The other thing is the Back to Work program. Some of the people here may not remember that program, some may. I thought that was one of the best programs we had, because I've had several people from my communities that were able to work but couldn't work because of an ortho problem. Most of it was ortho problems. So I don't know why we didn't fund it. It hadn't been funded the last 3 years, I know that. But I thought it was one of the best programs going to serve our working people. Some of them just couldn't work unless they had that done.
Yes, sir.
So I'd like to see that. I'd like this community to actually think about that again, is making some special funds for those type of people up there. A lot of them don't have insurance, or they work out, they work, I always call it hard labor, and they don't have insurance, and if they can't get that thing fixed, they just absolutely cannot work. The other thing, and I talked about this the last meeting I was here, and my concern is still here about recruiting and filling doctor positions in our clinics now, because I know within a year, we're going to really start recruiting to fill positions in our new clinic that's being built. So that's my big concern. So tell Stephanie to start recruiting double hard.
We have a couple of leads at J, and one of the things and I agree with all of you that have said that over time, and I know you've said it multiple times, Councilor
And just to
Buzzard.
clarify, they're more than leads. They've already signed letters of commitment and we're processing.
We talked to the recruitment staff and said, we have got to focus on the outlying clinics now. We've got to get them filled. We had a great recruitment meeting the other night in Tulsa. We have a lot of leads from that, and we really want to get all the clinics filled before we start recruiting, for the facility in Tahlequah in a year and a half or so. And so we are focusing on that very, very hard. And as Dr. Stalkup said, you can see that in this recruitment report, how many docs and advanced practice providers that we have that have made commitments to us.
Good deal, thank you.
Dr. Grimm, I have one last question. How are we going to staff the new facility once it opens?
So, we have approximately 850 new positions that we'll be needing to hire. We'll be transferring over about 400 from the existing outpatient services. We actually are going to have a multi-pronged strategy. And we had a meeting last week with Diane Kelly and her staff and IT, so education, IT. We got together, we started going over with them all of the new position types that we're going to have. They'd like us to outline for them which of those might need apprenticeships, which are going to need some kind of, higher education that scholarships would be able to help out with. We also have already pared down a list of kind of positions that we need to open the facility, because we're going to be keeping two facilities open. We have a listing that we shared with them too of the types of positions that we think we need just to help us be able to open that. So we're starting to work with internal departments. Stephanie and her staff was there. Our nurse recruiter was there. We tried to pull as many people around the table as appropriate to start those discussions right now. We're basically about 2 years out, we, the other thing I would let people know, that 850, that's not day one. Whenever Indian Health Service plans a facility like this, they do it on a 10-year horizon. And so we're several years in right now. It was a year in planning, not quite a year in architectural, planning and design, and now we're into construction. And so those count as part of those 10 years when they do the planning. So they don't truly expect you to have those 850 positions filled, for about 10 years out. As you continue to grow patients into it, I suspect we will have them filled much sooner than that, and we will be seeing more patients. That's often what happens, but from an expectation standpoint, if we were to look at it and just break it out evenly, 85 people a year sounds more realistic than 850, in 2 years. And one of the things we're going to do too is start looking at targeting what particular specialties we want to open. And for example, dental. Dental has a decent-sized staff to be able to move over into there, but they go from 12 chairs to 35 chairs, 36 chairs. And they will be able to hire a lot more specialists and general dentists. But they'll be able to open up just fine. But if they find a specialist close to opening, they'll probably try to hire them. And that's what we're going to do, because we have a number of specialty clinics that none of them have just one person in them. That was the other thing we said. You kill a person if you have just one specialist. They never feel like they can go on vacation and things like that. So the smallest number that we have in any of those medical specialties or surgical specialties are 2, 3, 5, 7. They're decent size offices for a rural area like Tahlequah. So that's in a nutshell that we have a lot to hire. We've already started working with people, plus we use our external recruiting like we always do. We started talking to Indian Health Service too about the increase in size that we're going to have and any help that we might be able to get from them. So we're reaching out to a lot of people right now, but it'll be a measured growth, but strategically measured.
Wonderful. Any other questions? Yes, Counselor Lay.
Got one more, thank you. The IHS health agreement, how many, I'm sure it's a large agreement, how many pages was that? Do you recall?
The compact, are you talking about for the joint venture?
Yes, sir.
Oh, it was big. It was probably, this is a guess, probably 600 some pages maybe.
I've GRA'd that, and I've been refused on that, and they told me I could come and look at it. And I used to have a photographic memory, but I forget when that memory was.
Well, it
So I
depends
knew
on
it
what
wouldn't do
part.
me any good to
It
go
depends
look
on
at.
what part you want to look at. It's broken up kind of neatly, you know. The agreement itself, the joint venture agreement itself is probably 25 or 30 pages. And it's these two other planning documents that we had to do called a program justification document and a program of requirements that are the 200 and 300 page documents themselves that are part of that agreement. It's all together. And so if you wanted to look at something in particular, like to see what, you know, specialties, there's a part on the medical specialty clinic. You can see what it kind of says we're supposed to have in the way of staffing. And there are a lot of summary tables that talk about the staffing that we're going to have and things like that. So it does sound like a daunting number, but if you're looking for something particular, it's pretty well laid out, and you know, and it's really, for a 600-page document, it's a pretty easy read. I like that kind of stuff. I kind of enjoy those kind of things, so maybe if you ask me what you want, I could remember it. I don't know.
I think I wanted the basic document from us to, or from IHS to us, government to government.
That's a smaller document.
That's
Yeah.
what I had. How many pages do you think?
It's
that-
probably, yeah, I'm guessing right now, because I don't remember exactly, maybe 30 to 40 pages.
I might could do that. Thank you.
Thank you. Okay, we're running late. Is there any other questions?
Just have one thing to say.
Yes, Counselor Shambaugh.
Just like to say thank you for taking the time, Dr. Stalkup, talking to me the other day and explaining the process on the denial for the referral. You know,
Oh, no problem at all, no problem at all.
At least
And-
I was able to explain to them why, and that's a big deal, you know, when we can tell them why, and or otherwise we don't know. And, you know, they may not like it, but then in the end, they understand. I appreciate your time.
And Counselor Shambaugh, I'm going to apologize to you and to anybody else. I think that everybody has my cell phone number, but if you don't, I'm going to give it real quick and you can write it down. It's
Just
Eric,
for all those
We're
recruits out
broadcasting
there.
live.
and any recruits out there can also call. It's area code 918-457-6928. And text messages are always a good way to get a hold of me, because I can get those even if I'm occupied in a meeting or something. But yeah, I'm happy to talk to you anytime there's any kind of question about anything. If I don't have the answer, I can get the answer for you.
Okay. One last thing too, Counselor Buzzard, we did get the audiologist some clerical staff too, just so you'll not having to do it all by himself anymore.
Okay, any other business? Okay, the meeting will stand adjourned. Merry Christmas.
Merry Christmas.